Okay, now coming towards the lecture, anemia in pregnancy. We will discuss thoroughly on it. My voice is clear to all of you, please. Please raise your hands if my voice is clear to you. Okay, fine. Now today we are going to discuss on anemia in pregnancy. What is anemia? It is actually a qualitative and quantitative reduction of the hemoglobin. Now what happens that once there is anemia in pregnancy, then it has got implications not only on the mother but also on the fetus. How it happens? Actually what happens that all of us you know that what normally oxygen is bound to the hemoglobin, and this oxyhemoglobin inside the circulation is following the is on the left side of the oxygen hemoglobin dissociation curve is on showing its curve towards the left. What does it mean? It means that inside the lungs the affinity of the oxygen for hemoglobin is increased. But once, please switch off the video and mic. Alina, please switch off your video and mic, please. Okay, now what happens that once this oxygen in hemoglobin is has come across the tissue level, then this oxygen hemoglobin dissociation curve, this turns towards the left, tends towards the right, sorry, and ultimately what happens that the affinity of oxygen with the hemoglobin is reduced, and ultimately this oxygen is delivered to the tissues, and this oxygen is responsible to carry out the aerobic cycle or various activities of the body. Now coming towards the normal content of hemoglobin in the pregnancy required. So according to the Center of Disease Control or according to the Society of Gynecologists of Pakistan, it is recommended that optimal hemoglobin value in the first and third trimester should be at least 11 grams per deciliters, and in the second trimester it should be at least 10.5 grams per deciliters. So we have discussed that according to Center of Disease Control or according to Society of Gynecologists of Pakistan, the optimal required hemoglobin is 11 grams per deciliters in the first and in the third trimesters, and 10.5 grams per deciliter. It should be more than this value. If it is less than that, then it comes under the category of anemia. And as I have told you previously, that actually this hemoglobin is bound to the oxygen and ultimately results in delivery of oxygen to the tissues, which is responsible to carry out the various cycles. Now once there is qualitative and quantitative defect in the oxygen carrying capacity of the blood, ultimately it will be qualitative in such a way that hemoglobin is not formed properly, and quantitative is in such a way that hemoglobin is reduced in the content, means the hemoglobin value is less than the normal. So as and we know that normally if we talk about the females, the optimal hemoglobin value varies between 11 to 15 grams per deciliters, but I have told you that in pregnancy it should be more than 11 grams per deciliters in the first and third trimester, and it should be more than 10.5 grams per deciliters in the second trimester. Now what are the maternal effects of anemia? So whenever there is anemia in pregnancy, what happens, as you know that oxygen carrying capacity of the blood is reduced in this way, so ultimately mother will feel fatigue, shortness of breath can be there is mental irritability, there is exertion on carrying out the routine physical activities, and also the patient experiences uh, easy exhaustion. Now this shortness of breath has to be ruled out, that either patient is having some lung pathology or is having some cardiac pathology. So ultimately you have to ask in detail about to rule out any other pathology either in the lungs or in the uh, heart. Now furthermore, what happens that patient, as we have told you, I have told you that this the patient presents to you usually depending upon the severity of anemia, as we know that if the hemoglobin content is less than 7 grams per deciliters, it comes under the category of severe anemia, and if it is less than 4 grams per deciliters, it comes under the category of very severe anemia. So ultimately the features also vary according to the severity of the anemia. That patient will be having extreme fatigue and pallor, and she will be having shortness of breath, and she will be experiencing easy fatigability. And definitely once you will examine this patient, you will see the conjunctiva, it will be extreme pallor, there will be extreme pallor, and also you will you can see this in the by checking her nails, by seeing the palms and seeing the conjunctiva. So ultimately after carrying out the routine tests and asking about certain questions to rule it out that either because of anemia or because of some other pathology, you will perform certain tests, and the baseline test in that case to for anemia is usually the complete blood picture. Now I was telling you that it has got maternal implications and anemia has got the fetal implications. How the fetal implications actually, if the hemoglobin content is reduced, then definitely the oxygen carrying capacity of the blood is also reduced. So reduced perfusion of the fetus will be there as well, and this in turn ultimately can result in intrauterine growth restriction. And also if there is anemia, this can lead to intellectual impairment in the fetus as well. And also what happens that patient can experience preterm contractions because she is in stress because of shortness of breath. And all of you know that whenever a mother is in stress, there is release of cortisol, and this cortisol in turn induces the labor. So she can experience the preterm labor. Also, if there is some improper oxygenation of the body tissues, then this patient is prone to have infections like urinary tract infections. She is prone to have the urinary tract infections repeatedly because of this. And also the as well as the fetus is concerned, the intrauterine, there can be intrauterine growth restriction, there can be preterm labor, and there can be intellectual impairment of the fetus. And also if the patient is not having much reserves, her hemoglobin value is very much low, then in that case the postpartum hemorrhage can be there, uterine atony can be there, which is actually the relaxation of the uterus, and in this in turn the postpartum hemorrhage can result in severe morbidity and mortality of the to the patient, like increasing the risk to the maternal life. So if as we have discussed that certain investigations are confirmed to rule it out that either it is anemia, and what is the type of anemia, because actually as we have discussed previously that anemia is qualitative and quantitative defect of the hemoglobin. So quantitative means that there is less hemoglobin content, and qualitative means there is abnormal hemoglobin formation. So you have to carry out certain investigations to see and to type the anemia. So what do we normally see in the complete blood picture? Normally the values we see is that first of all we see the hemoglobin value. We see the hemoglobin content in grams per deciliters, and we compare it with the normal value. Then also we see the WBCs, that is total leukocyte count, which actually is raised in case of infection. So it can also show anemia, because in anemia the body is prone to develop infections, and ultimately the WBC count can be raised. And the next thing is that normally we see the red blood cell indices. The red blood cell indices actually mean that we see the mean corpuscular volume, we see the mean corpuscular hemoglobin, and we see the mean corpuscular hemoglobin concentration. What is corpuscular mean? Corpuscle means cell, that is a red cell. So mean corpuscular volume means what is the normal volume of the red cell. So the normal value is given actually in as femtoliters, and this is actually 70 to 90. So if this value is in the normal range, it means it is normocytic, means neither micro nor macro, but it is normocytic. But if the mean corpuscular volume is going to be reduced, then it may be hypochromic anemia, means the cell size is going to be reduced. So next thing we are going to see is mean corpuscular hemoglobin, means per cell, per red blood cell, how much hemoglobin is there. So the normal value is actually from 32 to almost it's about 28 to 32 picograms, and also the normal value, then we see the mean corpuscular hemoglobin concentration, like overall what is the average level of hemoglobin content per red blood cell. So the normal value is actually 32 to 36 grams per deciliters. So these three values are very much important because they are giving you a baseline picture about the type of anemia and about the RBC's shape, size, and the hemoglobin content. So according to this, either there can be hypochromic macrocytic anemia, there can be macrocytic anemia, or there can be normocytic. So macrocytic is actually the, as all of you know, it is megaloblastic, which is in case of folate deficiency, the RBCs are increased in the size. In case of iron deficiency, the RBCs are reduced in the size, so ultimately the patient develops hypochromic macrocytic anemia. And normocytic is actually when there is acute blood loss. For example, patient is bleeding, so in that case there can be normocytic anemia. Now the next thing we do is peripheral blood picture. In the peripheral blood picture, we see that abnormal size and shape of the cells, like it is termed as poikilocytosis and anisocytosis. So poikilocytosis means abnormal shape of the cells, and anisocytosis means abnormal size of the cells. So in this way, ultimately, if there is abnormal size and shape of the cells and hypochromic in macrocytic picture, this also indicates there is iron deficiency anemia. But out of all these baseline tests, we go for the screening test, and the diagnostic test, and the diagnostic test is serum ferritin value. Now serum ferritin value, you must remember, it is actually the iron content of the blood, and so the normal value is from 15 micrograms to 300 micrograms. So you have to see the ferritin content. So the first thing, by seeing the serum ferritin value, should come in your mind that if it comes in the normal range, it means that it is not iron deficiency. If it is below the normal range, then definitely it is the iron deficiency. And if it is above the normal range, then it is not iron deficiency, but some other pathology is there, where already, although patient is having anemia, but at the same time there is hemolysis, and because of that there is liberation of ferritin in the circulation, and the ferritin values are increased, and that is actually seen in case of thalassemia. So we will discuss thalassemia in detail in the next lecture, inshallah. Just I wanted to tell you about the basic things that you should remember in your mind, that actually in anemia the very much important screening test, first of all, definitely you have to go for the complete blood picture, in which specifically you see the hemoglobin content in grams per deciliters. You also see the white blood cells which are showing some infection. If the patient is bleeding, then definitely you will also see the platelet count value, and also in this case the red cell distribution width, RDW, is mentioned. this RDW actually is increased in case of iron deficiency anemia. So, whenever you come across some CBC picture, please make a habit to see these values, so that it becomes reflexes to interpret the report of a patient with anemia. Now, as I have told you that the next test was red blood cell indices and also the peripheral blood picture, and the confirmatory test was serum ferritin, and I have told you the normal value of serum ferritin. And one thing very important in our setup is actually that because of poor hygiene, normally the females, they are anemic. So, we have to either we have, if the patient gives you history that she has history of passage of worms in the stool, or she experiences perianal itching, then you have to confirm it, and it is actually the stool for ova or cyst. But because of some technical reasons, like there is risk of contamination, difficulty in sample collection, and also proper result interpretation is not there, so then you just deworm the patient. But for theoretical point of view, you have to mention that we will actually do the stool for ova or cyst in for consecutive 3 days if the patient has history of passage of stools in the passage of ova or cyst in the stool, or she has a history of perianal itching. Now, further how to treat this patient. First of all, you must remember that iron is available in the form of oral preparations, in the form of IV or intravenous iron, and in the form of the blood. As far as the oral preparations are concerned, there are different preparations, and out of this the gluconate has got the least content of elemental iron, which is about 35 milligrams, and then sulphate, that is actually ferrous sulphate, which usually we take, this has got about 60 milligrams of the elemental iron, and the fumarate has got the largest content, which is actually 65 milligrams of the elemental iron. Absorption is there. So, you must remember that actually the absorption of iron is occurs at the level of small intestine. If the patient is having some gut disease, or she is having some malabsorption, or she is having some intestinal infection, then in that case definitely the iron absorption will be hampered, and in that case you have to manage the patient accordingly. Now, what to give in what circumstances? This is a very important thing which you have to choose according to the patient. For example, if your patient comes in the category of mild to moderate anemia, and there is no emergency, then you can give either oral iron versus intravenous iron. Now, the first preferred choice is oral iron, which is in the form of as I have told you, different preparations. But if your patient is not compliant to the oral iron, either she has oral thrush, or she has gastritis, or she is having some irritable bowel syndrome, or she develops constipation after taking iron, or she is not compliant with the oral therapy, then in that case we have to give the intravenous iron. Inshallah, we will discuss in detail. I will share you the lecture about GYNAE formula, where we calculate the iron deficit, and according to the GYNAE formula we replace the intravenous iron, and this is actually this immediately gives you the iron stores, and ultimately we get the value of hemoglobin done after 3 weeks to see that what the level of hemoglobin has been there, and definitely the symptoms of the patient, that is shortness of breath, fatigue, irritability, all are improved. And if the patient is in the category of severe anemia, then you have no option except to transfuse the blood. So, definitely you will transfuse blood to your patient, and once she feels better regarding her symptoms, then you will either put her on oral iron or intravenous iron, depending upon the compliance. And to avoid the risk of postpartum hemorrhage, you have to arrange the blood so that there is no risk in case of high risk pregnancy. And regarding the postpartum hemorrhage, if the bleeding is more than 500 milliliters in case of vaginal delivery, it comes under the category of postpartum hemorrhage, and or if the bleeding is more than 1 liters in case of operative delivery, or C-section, again it comes under the category of postpartum hemorrhage. So this was all a very basic lecture on the anemia and pregnancy. I just delivered to give you the main points regarding anemia to study, so that the basic things are clear to you. Is there any question you want to ask? The lecture is clear to all of you?
Yes, ma'am.
Okay. Okay, inshallah, then I will share with you the next lectures, inshallah. And further, I think thalassemia is an important topic which is quite confusing. So, inshallah, I will discuss in a live session thalassemia as well. So, okay, thank you very much. I think we should end the class now. Okay, Allah Hafiz.